Vamos a comenzar una de las conferencias principales de este congreso y el Comité Científico Local y el Comité Científico de SENPE han propuesto abordar el tema de los criterios diagnósticos de desnutrición. Como sabéis, uno de los hitos más importantes en los últimos años ha sido el establecimiento de los criterios GLIM, que comenzaron por unos criterios ESPEN de desnutrición que se publicaron en 2016 y después hubo una iniciativa global para definir la desnutrición y son los criterios de este grupo de líderes global, se conoce como GLIM, y uno de los participantes en este grupo desde el principio fue el profesor Rocco Barazzoni. Dentro de esos criterios diagnósticos ya sabéis que un punto clave es la definición del estado de masa muscular y la posible pérdida muscular. Creo que somos muy afortunados por contar con la presencia del profesor Barazzoni con nosotros y con la presencia también del profesor Rafael Carmena, que va a presentar a nuestro invitado de honor. Muchas gracias, profesor Carmena.
Muchas gracias, Miguel. Buenos días. Es un privilegio contar, como decía el doctor León, con el doctor Barazzoni para esta conferencia. El doctor Barazzoni, Rocco Barazzoni, es profesor asociado de Medicina Interna en la Universidad de Trieste y actualmente es el presidente de la ESPEN. Su investigación se ha centrado y se centra en la regulación nutricional y hormonal del metabolismo energético, la función mitocondrial, el estrés oxidativo, la inflamación y la resistencia a la insulina, tanto en la experimentación clínica como experimental y con el foco puesto en la obesidad, sus complicaciones metabólicas y la malnutrición. Es el autor de más de 140 trabajos en estos temas, incluyendo su investigación original, también editoriales, y por supuesto documentos de consenso y guías como las que va a presentar hoy. Professor Barazzoni, it's a pleasure to have you here, and we are all looking forward to listen to your lecture on summary assessment and the importance of muscle mass, when you wish.
Okay, well, buenos días a todos. Gracias por la introducción y por la invitación a SENPE. I'm sorry, this is all my Spanish, I'm afraid, for today, but it's really a honor and a pleasure to be here. Personally, and also on behalf of ESPEN, I really thank SENPE for inviting me. And ESPEN and SENPE have, for many years now, a very strong collaboration. SENPE is a very important society in the European and also international scenario, giving lots of contribution also to the GLIM initiatives and to many other scientific and clinical activities of our European society. So it's really a great pleasure and congratulations. Congratulations for this excellent Congress. Big rooms, always full. I see a lot of activity, enthusiasm. So again, it's really a pleasure. The topic that I have been assigned is, of course, very important to me, and I think in general to the clinical nutrition community. It's a big opportunity that after many years we have now a consensus definition and criteria for diagnosis of malnutrition. I think it's important to help us to introduce clinical nutrition and malnutrition in the routine assessment of all our patients. I have no conflict of interest for this lecture. My only conflict of interest, let's say, is that I am a GLIM enthusiastic supporter. So you should know about that I am very much in favor and convinced of the importance of the GLIM initiative and approach. This is the outline, since we have, I hope, the luxury of time this morning, and I also thank SENPE for giving me the opportunity to speak in this plenary lecture with several minutes, let's say, of time at our disposal. The outline is also beyond muscle. I will try to introduce, again, to summarize what is GLIM and what is the purpose of this initiative. Where we are now, because GLIM was published 4 or 5 years ago, and what is the status of validation and implementation. Then, of course, focusing on skeletal muscle mass, which is the key topic of the lecture, and in particular, the role of GLIM in identifying low skeletal muscle mass in malnutrition and the overlap with the concept of sarcopenia, and then a few perspective activities that are in the pipeline, let's say. I think we are all familiar with the GLIM algorithm, but just to summarize, GLIM stands for Global Leadership Initiative on Malnutrition. It is an initiative that was launched officially 4 years ago with the publication of 2 joint papers in Clinical Nutrition and JPEN, with the, let's say, leadership of the 4 major international societies, but also leaders from many national and regional societies involved. Truly a global process. And the GLIM requires a screening, a positive screening for risk of malnutrition. We know that there are many tools for that. I will not go into the detail. And there are then 5 criteria. 3 phenotypic criteria and 2 etiologic criteria. We call the phenotypic are unintentional weight loss, low body mass index, and low muscle mass. And the 2 etiologic criteria are low unintentional, let's say, food intake, not a purpose diet, or malabsorption, and the presence of disease with a component of inflammation. 1 phenotypic and 1 etiologic criterion are needed for the diagnosis of malnutrition according to the GLIM. So the global idea behind this initiative was to really prepare a simple tool, a relatively, let's say, simple tool, with potential also for application in routine clinical practice, not only in specialized, highly technological, let's say, centers, but also in theoretically more simple outpatient clinics, based on global consensus. Again, this is really an important point, which requires relatively moderate training and then allows also implementation potentially by non-nutrition specialists, allowing to introduce malnutrition also in other disciplines, which is also, I think, an important goal. Tools and methods for the diagnosis should be available, relatively available in many clinical settings, including, and I will go into this in a few minutes, the way to assess muscle mass, which should include, again, simple tools, potentially, if not technological tools are available, also anthropometry and physical examination. So the goal is really to reach out to every healthcare professional potentially for routine patient assessment to implement nutritional care for the treatment of every patient. Then, of course, with a relatively simple GLIM approach, the initial papers also already envisioned that when we have a diagnosis based on the GLIM criteria, then we need a full specialized assessment. So GLIM is not in competition with the assessment tools that we are already using, like subjective global assessment, mini-nutritional assessment for older adults. We know that all these, let's say, tools include more aspects than just the GLIM. So they are more complex. They include the etiology of the malnutrition process. They include functional assessment. And also we will discuss this in a few minutes. And so after the GLIM diagnosis, if and when possible, a specialized healthcare professional in nutrition, a nutritionist, a skilled dietitian, the nutrition team should be involved to optimize the diagnostic approach and also to set up a treatment plan and monitoring plan and follow-up. So this is not competing with the full nutritional assessment, but hoping to expand the possibility to diagnose malnutrition in every patient. Where are we? This was 4 or 5 years ago, as I said. The initial approach from the GLIM group was, okay, maybe now we need validation, but we also want to implement these criteria. And the big question was, do we really need validation of the GLIM? Because all the 5 criteria individually, each criteria is very familiar to all of us. We know that these 5 criteria have been used for several years. They are individually validated. We know that they have some strong relationship with clinical outcomes. So it's really maybe a bit redundant, let's say, to say we need a full validation starting from scratch as if all of this does not exist. So individual criteria have been validated. We want to have a validation of the GLIM as a tool, but also we want to start with implementation. And also, an important point is, what should we validate the GLIM against? What is the comparator? What is the gold standard? Okay, we know that there are other tools that we have been using, including, as I mentioned, SGA, MNA, Subjective Global Assessment, and others, but these tools are not exactly the same. As I said, they are more complex. They include additional components such as mobility, cognitive function. We are aware of that. The patient, is he or she institutionalized? Even polypharmacy is included. All these things add to the clinical burden. So I think it's not fair to compare the GLIM, which is a simple, focused tool on nutritional components, with other tools that are more complex, more comprehensive, and more potent, maybe, in identifying clinical outcomes, but then again, not only focusing maybe on specifically nutritional components. It's a little bit like comparing apple and oranges, if you allow. So again, we probably have a unique opportunity with the GLIM to focus on a simple approach based on truly nutritional criteria. But having said that, as I said, so we expect, and maybe it's a little bit ambitious, but we expect the GLIM to work. So in the beginning, the community said, let's work on validation, because we need to prove that the GLIM works for regulatory agencies. If we want to propose the GLIM to officially replace the existing diagnostic criteria, for instance, in the ICD, in other documents, we need some validation, some papers to say, okay, it works. We need the common databases. We need also to learn about how the criteria combine. So let's work scientifically on the GLIM, but also let's start using the GLIM. This was definitely a strong message from the community in nutritional care every day. This is ready for implementation. I will spend a few minutes now to summarize what I think is the encouraging results from 4 or 5 years of validation of the GLIM in clinical research. And I would like just to make a very short comment initially, because if we want to really validate, we need rigorous methodology. It was described by the GLIM group from the start. First of all, we need all the 5 criteria to be collected and let's say, tested. It's not okay to say, okay, this patient does not have malnutrition if we only have 2 or 3 criteria used. I hope this is obvious, but we have to use all 5 criteria, especially to exclude malnutrition. If we have 2 or 3 criteria and they are all positive, maybe we can already say this is malnutrition. But on the other hand, we have to use all 5 criteria before we can say there is no malnutrition. And then it is ideal, like I mentioned, to start having combination analysis. Maybe in some situations, 2 or 3 criteria are more useful, like, for instance, in cancer patients, weight loss and disease criterion combined are the most potent diagnostic approach, and maybe we can simplify the approach in some disease conditions. So we need to combine the criteria and look which is the most effective, but all 5 need to be used now, and we need a rigorous statistical approach. This was explained in papers that were published just after the algorithm was proposed again 4 years ago. I think that the results are very encouraging. I checked a few days ago, the citations in the literature are more than 1,600 for the GLIM papers, combining the different publications, and more than 300 papers have the Global Leadership Initiative on Malnutrition as PubMed search term, and more than 250 have a sort of approach to validate the GLIM criteria. So I think this is very encouraging. There is a lot of enthusiasm, I would say, hopefully. I'm a bit, as I said, optimistic and a supporter of the GLIM approach. So I interpret this as a strong enthusiasm about the GLIM. A few examples of how the GLIM could be really seen as a successful and important tool for clinical practice. This is I would like to start with a review that I published a few months ago together with my friend and colleague. Actually, this is more his work than my work, Tommy Siderom, who is one of the fathers, let's say, of the GLIM. We have looked in this particular review specifically on older populations. It was published a few months ago in the fall of 22, and there were 40 GLIM clinical trials on older populations, only in 1 year. You can see how global the approach is. Of course, it's more from Europe and Asia combined. They put together a majority of the papers, but there are also from Latin America, Australia. I don't know, it's working by itself, a little bit independent here. I maybe have to keep my hands off the podium. But anyway, it's a truly international effort for validation of the GLIM. And you can see the clinical settings are very heterogeneous. Mixed settings like hospital patients with no specialty, cardiovascular disease, diabetes, COPD, all of the major diseases are involved, and geriatrics, of course. And there are one strong meta-analysis that we considered. Many of the papers did test the GLIM against established tools like SGA, and I said, I told you already what I think, that it's not completely fair to compare these two type of tools because they are not exactly the same, but they were tested, and the predictive validity of the GLIM against major outcomes, including mortality, was also mentioned. And to summarize, the results of this review were very positive. The criterion validity comparing mainly with SGA was at least moderate to good, and like I said, it can never be perfect since the tools are different. And the predictive validity was at least as good as any other in predicting mortality or hospitalizations and other major clinical problems. So I think that this is very encouraging. The major meta-analysis that I mentioned, including more than 10,000 patients from heterogeneous scenarios, it concluded that the results were very positive, and the GLIM criteria have the potential to be used as the gold standard for diagnosing malnutrition. So again, I think very encouraging. Just a few more meta-analyses that I find in the literature. There are more than a dozen, I think, now strong meta-analyses. Cancer has been studied very substantially. Again, the GLIM is a very good predictor for mortality in cancer patients. You can see here there are already at least 10 studies out there, including one from a CISPEN group that I have been involved in. So very convincing that GLIM is useful to predict outcomes. The EFFORT trial, I think that we are all familiar with this one, I hope. It's been a very strong message to say, okay, nutritional treatment in hospitalized patients at risk or with malnutrition is effective in reducing mortality, in improving outcome. It's a strong papers published in Lancet and JAMA in the last 2 or 3 years. There has been also an analysis using the GLIM criteria to define malnutrition. And you can see here that it was also very encouraging because GLIM was able to predict survival. Several other tools were also able to predict survival in a similar way in the EFFORT trials, but only GLIM was able to predict response to medical nutrition treatment. So again, a very encouraging result. And there are also many other chronic diseases where GLIM has been implemented. One that is not very, let's say, commonly associated with the concept of malnutrition is heart failure, for instance. And you can see here that the GLIM in heart failure patient was again able to predict survival through malnutrition, to also predict low muscle strength, and we are moving to skeletal muscle now, and physical performance, and also when renal failure, for instance, so a combination of two major chronic diseases were present, still the GLIM and malnutrition were independently able to predict mortality and negative outcomes in these patients. So I think that it's very encouraging, and we can say that the GLIM is being more and more validated, as we mentioned before. So much so that we already decided in the meantime to start one of the processes that we were hoping to start when the GLIM was envisioned, which is to approach regulatory agencies to introduce this new definition of malnutrition as a standard definition in clinical practice. One of the institutions that we know is very important to define malnutrition in clinical practice is the ICD, International Classification of Diseases. The current definition is, I think, okay, a shame, I will say, my very honest assessment, which is still based on low BMI, which we know is clearly not sufficient to diagnose malnutrition in our patients nowadays, and older definitions like Kwashiorkor and Marasmus. We are proposing now, based on the GLIM, with the strength of the global consensus, with more than 40 clinical nutrition societies supporting this request, to modify the criteria using, again, the 5 criteria of the GLIM for a new diagnostic approach for malnutrition in adults. It's a long process. It started during the pandemic in 2021. We are told by our friends, let's say, at WHO, that we have to be patient. We had a meeting. So we started with a direct discussion with WHO, which manages the ICD, about a year ago, 10 months ago in 2022, and they were very encouraging, but we provided additional information. We are hoping to hear soon more about the potential change in ICD based on the GLIM. And again, we have another added value, which I think is very important, which is we are finally speaking a common language. I speak about the GLIM not too often, but fairly often, and I see that this is a language that is spoken in the SENPE Congress, in Turkey, in Brazil, in many other places. So we have something that we can understand each other when we speak about malnutrition. I think it's a huge step forward, and I think already this is a very important achievement of the GLIM. Having said that, I think that we can move towards the more focused topic for the presentation today, which is skeletal muscle mass. Skeletal muscle mass is, I think, more and more recognized as a very important component of the malnutrition phenotype, and also a general predictor of negative outcomes in medicine. Low muscle mass is an important outcome, independent predictor of outcome, also independently of malnutrition, but of course it is also a major component of malnutrition. So in this respect, since I have spoken now for 15, 20 minutes, I cannot check very closely here, but I've spoken about the GLIM, saying, okay, this is very promising, very encouraging. Is this perfect? Okay, I'm not that ambitious. GLIM is not perfect, and we can improve. Of course, GLIM is especially not perfect maybe for skeletal muscle mass, but not because of the GLIM, because skeletal muscle mass assessment is difficult for routine clinical practice. We know that we have, 2 criteria that are the phenotypic criteria of weight loss and low BMI, which express the quantitative component of nutritional homeostasis, body mass. But we also know now very well that nutritional homeostasis is also about body weight quality and body composition in particular. So low skeletal muscle mass also has clearly a very important role, and we need also to more and more assess muscle mass in routine clinical practice. The GLIM already in the beginning recognized that reduced muscle mass is a strong phenotypic criteria. It needs to be included, but there is no consensus currently, we speak about 4 years ago, regarding how best to measure and define reduced muscle mass, particularly in clinical settings. We have research, of course, we have sophisticated measures, but if we want to do it in our outpatients clinic, if we want to do in the hospital, if we want to do it everywhere in the world, not only in the, let's say, more wealthy or more developed, whatever that means, countries, but everywhere. So the GLIM, let's say, consortium decided to create a GLIM body composition initiative, again with the 4 societies and many representatives, which I had the honor to be appointed to coordinate together with Charlene Confer from Aspen, and there were, let's say, an advisory board and about 30 members from all over the world in this initiative. And the questions for this group were to provide a better guidance, a better clarification on how the skeletal muscle mass criterion should be implemented in clinical practice. What are, first of all, the acceptable tools and devices for measurement and assessment of muscle mass? Again, with the perspective of applicability, not what is the best tool, what is the perfect tool, what is the gold standard for research. That's not the goal of the GLIM, but what are the applicable, acceptable tools for clinical practice. And then the other 2 questions, which are also very ambitious, were what are the cutoffs for these tools and devices, and let's define once and for all, let's say, the role of muscle function. Is it part of malnutrition? Is it something that we should use to define malnutrition? Or how should we approach muscle function? And we will come to discuss sarcopenia through that. But starting with the tools and devices, the decision was, again, to be inclusive. We don't want to exclude, we want to use the devices that have proven to be able to predict clinical outcomes. And then we know that the devices are not all the same, that there are very accurate devices, very sophisticated devices that unfortunately are less available for clinical practice, and there are devices that are very available, let's say relatively easy to implement, but are less accurate. Let's find the balance, and maybe this balance will tell us when to use each device in which clinical condition. And then the other important component is whatever the tool, whatever the approach, we need the expertise. So if you have a very sophisticated DEXA or even more sophisticated machine, but you have nobody to use it, then the device is not applicable in your practice. On the other hand, if you have the expert, you can use a very sophisticated technology. And so this is also another important point. This is the statement that I summarize here in the papers that was published from this initiative last year. In general, the use of validated tools, again, validated means they have proven to predict clinical outcomes. It's always acceptable based on the availability. Is it in your clinic available? Reference values, and it's not every time that we have all the values for each condition, but there are many conditions where we can use cutoff values that are available, and operator expertise. If this is available, you can use for measurement of skeletal muscle mass, or its surrogate as a fat-free mass. We don't always measure directly muscle mass. We have appendicular limb mass, skeletal muscle area, but all these surrogates are acceptable. So the techniques are, in practice, bioelectric impedance analysis, BIA, dual energy X-ray absorptiometry, DEXA, and computer tomography when it is available. We know that some of these are not always recommended just for diagnosis of malnutrition. They are available for other reasons, for cancer, for other diseases. If they are available, let's use them. They are recommended for measurement of muscle mass. We added ultrasound, which is a little bit less validated, but very promising because it's easy to use in clinical practice. For instance, we know that DEXA and CT, again, are the ones that are most accurate, but we need special expertise. Sometimes there are X-ray exposures that we need to consider, not very often. And we need another indication. Like I said, unless the patient has another disease, it's unlikely that we can ask for a CT scan just to diagnose malnutrition. So there is this kind of a balance to consider. BIA, we know it's a good compromise. We think there are limitations, especially because of the assumptions that we know are needed for equations. We don't know sometimes even the equations that are used for a specific machine, but we know that they are available and they are easy or relatively easy to implement, also in outpatient clinics. So we should definitely encourage the use of BIA, being aware of the limitations. So using them, knowing that they are not perfect, and also, again, ultrasound has the same kind of approach as BIA. It is relatively available also for outpatients. It's accurate when it is well implemented, when the operator is experienced, when there are the same operators, reproducibility is better. So we need, I think, protocols for implementations of each of these techniques. So ultrasound is also recommended by the group. But this is not finished, because when there are not technical approaches that are available in your practice. Let's say you work in an outpatient clinic, or you are working in a part of the world or a part of the country where there is no sufficient resources for this kind of techniques. Then the use of anthropometric measures like calf circumference or mid-arm circumference, and also physical examination for muscle mass, of course, not general physical examination, but a specialized examination, for instance, by skilled dietitians, they are also acceptable due to universal availability and according to preference and training. Again, the accuracy, relatively speaking, is good. Of course, it's not as good as the technical approaches, but it's so available that it is impossible. I think it's not fair to exclude them just because they are potentially less accurate. We know that circumference are able to predict outcomes. In particular, calf circumference is relatively easy, and it has been demonstrated to be very reliable. So let's use them is one of the messages of the group. And also, like I said, physical examination, which is already part, for instance, of SGA and other methodology. What I personally think should be considered as a sort of a limitation is that the subjective component of physical examination, and we are all aware that this is potentially an issue, but for skilled professionals, this becomes less of a limitation, and it was decided by the large group of experts that were preparing this guidance paper to definitely accept and include also physical examination. So the summary algorithm that I would like to maybe propose to you is, okay, let's be inclusive, use technical approaches when they are available, when we have cutoffs, which is more and more the case, DEXA BIA, ultrasound, CT scans. If they are available, okay, we have a measurement. If they are not available, let's go through clinical approaches. There is, I would say, no excuse. Clinical approaches are always, I would say, more or less always available, and then we can define muscle mass. Cutoffs, like I said, it is a limitation, especially if we want to say, okay, we need a cutoff for Caucasians, Asians, of course, gender is an important factor for cutoffs, obesity, which I will speak about in the final part of the presentation. I think this is all very clear. We need to have specific cutoffs, but we should not be too demanding of cutoffs also. We are also promoting an initiative after this initial body composition guidance group has finished and published the work, to really provide a meta-analysis of cutoffs that are available. And we are preparing, I'm not leading this group, other colleagues are, but we will aim at preparing a large paper, a large summary of cutoffs that are available to define potential specific limitations and all the factors that I mentioned, ethnicity, gender, age, and potentially disease specificity. But we already should use the ones that are there. Finally, the role of muscle function. Muscle function is important in the nutritional assessment of our patients. Functional assessment like hand grip strength was mentioned in the initial papers as a potential supportive measure for malnutrition diagnosis. So we realized that we needed maybe some clarity about is function a part of malnutrition diagnosis, or is it maybe an addition to malnutrition diagnosis? Functional assessment is important, but muscle mass and function are not superimposable. Sometimes muscle is low, but function is preserved. Sometimes it's the other way around. We know that the causes of reduced muscle mass and function may be different, and muscle mass and function overlap in the diagnosis, for instance, of sarcopenia, like I mentioned, and also frailty. We know that the definition of sarcopenia, which comes from the geriatric world, the geriatric specialty, but is also very common in disease conditions, low muscle mass and function. This is the definition of sarcopenia. So it's different from malnutrition, it adds the functional component, and it's also a very strong predictor of negative outcomes in older populations and also in other disease conditions. So the conclusion from the group was, although it is important, the measurement of muscle function is not advised as a surrogate for muscle mass. Once we have a diagnosis of malnutrition, the function should be investigated because it's part of nutritional assessment anyway, so we should not neglect it. But we should also consider that it's part of other concepts, including sarcopenia. So when we have a diagnosis of malnutrition, we should fully assess our patients and also assess for sarcopenia. In general, there is this overlap based on muscle mass, which is reduced in both concepts. The trajectories are a little bit different. I think that malnutrition is more focusing on the presence of disease, on the presence of catabolism, and again, of mass. And the sarcopenia concept is more focused on the prevalence of function coming from the, let's say, geriatric approach with a gradual, more, let's say, physiological reduction of function. But they both overlap. They have a synergistic negative clinical impact, and the common message is they should be assessed in an integrated fashion. We know that there are ways and algorithms that have been suggested by, let's say, geriatric groups. This is the EUGSOP, the European Working Group on Sarcopenia. I'm sure you might be familiar with this, including screening through questionnaires or clinical suspicion, assessing, first of all, muscle function, which is the difference between malnutrition and sarcopenia, then muscle mass, and then the diagnosis of sarcopenia is made, independent of other nutritional components. So this is the big difference. What I would like to mention in the last 10 minutes maybe, is the important role of obesity. Because I think that obesity is a major focus for me personally, but we are more and more succeeding in bringing obesity and the nutritional components of obesity. Not obesity per se, not obesity as too much fat, but also obesity as a double burden of also malnutrition and sarcopenia, which is not very well recognized, I think, in the clinical community. We know that the WHO accepts that there is a double burden of overnutrition and undernutrition in obesity, but in the official definition, it is limited to micronutrients. And I think it's not enough. I think we all have to agree that, as we mentioned already, the phenotype, including body composition and body quality, we have to recognize that many patients with obesity have an excess body fat, but they are also not able to protect their muscle mass, so their excess body fat is associated with low muscle mass. This is almost inevitable in aging. We know that in aging we have a primary, almost inevitable dual alteration of nutritional status, which includes sarcopenia, as we mentioned, so low muscle mass with accumulation of body fat. So there is a primary body composition derangement if obesity starts in older age, but we also before old age, obesity can be associated with muscle catabolism. Because of adiposopathy, adipose tissue becomes a source of inflammation, of insulin resistance, hypertrophic adipose tissue and adipose cells become dysfunctional, and they generate cytokines, insulin resistance. Ectopic fat deposition also is a cause of altered metabolism, and skeletal muscle mass can be reduced. Also, obesity is a risk factor for many diseases. This is very common. We know that polymorbidity is very frequent in persons with obesity, and we know that multimorbidity is a further hit for catabolism in skeletal muscle, and this can happen again at any age. And we also know, I will not go into detail here, but when we have this excess fat with the additional risk for low skeletal muscle mass, in particular, like I said, for aging and persons with the comorbidities, this has an important clinical consequence. We have a risk factor for many complications, insulin resistance and type 2 diabetes, reduced fitness with worse cardiac and respiratory complications, frailty, disabilities, more hospitalizations and mortality. There is very strong evidence. I will not go into detail for that. I would like to propose this approach for obesity as a truly maybe natural history of this disease. We can probably simplify obesity as a disease of excess fat when the patients are younger, when the history of obesity is not very long, and when there are, whatever that means, if it is possible, no comorbidities. But when we have older patients and comorbid patients, we should probably assume that we are facing a body composition disease where excess fat is associated with muscle loss. Coming to malnutrition, we know that our GLIM criteria very well allow to diagnose malnutrition in this setting, because persons with obesity, okay, let's exclude the BMI criterion, because the BMI by definition will be high, but they may have unintentional weight loss. Let's think about a cancer patient who is losing 5–10% of the weight, still obesity range BMI, but unintentional weight loss is there, and low muscle mass. Again, that is very, very possible and common. So malnutrition can be diagnosed in persons with obesity. Then malnutrition with low muscle mass, of course, may have a functional impact, like I mentioned. We mentioned how function needs to be included in the nutritional assessment, but also I would like to mention and remind you that this can lead to sarcopenia. So sarcopenic obesity is also a concept, not only in persons without obesity, but with obesity, sarcopenia is a concept that we should consider and try to diagnose. So I would like to finish my presentation information before moving to a few perspective initiatives for the GLIM by introducing, maybe again some of you are familiar, a few months ago we published another document which comes from a joint initiative from ESPEN and EASO, which is the European Association for the Study of Obesity, and a large group of international experts, including several Spanish experts, by the way, which are included in all the other initiatives that I have mentioned, which is a new algorithm to diagnose sarcopenic obesity. The need of this is similar, I think, to the GLIM. We have a concept, we have awareness maybe starting in our community that sarcopenia is important and sarcopenic obesity is also important, but we have no common language to identify and diagnose sarcopenic obesity. So consensus is the key word, and we hope that this approach with screening, again, I will not go into details, it's a simple screening approach based on BMI and waist circumference with clinical suspicion. Then we need to have muscle function, again, first assessed. If there is no muscle dysfunction, we have no sarcopenia. If there is a low hand grip strength or low sit to stand, these are the two tests that we are recommending, then we should go to body composition. DEXA, BIA, and CT when available. You can notice that we try to be consistent with the other documents and approaches that we propose. And then we have a staging criterion, a staging approach, which I will not go into detail. I think that this is very encouraging. We already have more than 110, 120 citations. This was published in Clinical Nutrition and Obesity Facts, the Journal of the Obesity Society, only, let's say, 6-8 months ago. So we are very pleased with the acceptance of the paper so far, and we have a few papers that have started to implement. I'm very happy to present a paper from my group that we have, out of a very sheer excitement and curiosity, try to implement the algorithm in a cohort we are following in Northeast Italy. It's a very small group, 70 patients, older adults, living in the community, a primary care, very simple assessment using hand grip strength and BIA. And you can see that the sarcopenic obesity prevalence is 10% in this group, which is quite large because these are people that are living, like I said, in the community, not institutionalized or frail or anything. And we identified a few risk factors, which I will not go into detail. It is accepted for publication in Metabolism only a few days ago. So at this point, I think that I hope that I have tried to convey the message that the GLIM is an important achievement which has proven to be useful and successful already. I think that skeletal muscle mass is an important component because it's more and more important in medicine, not only in nutrition, and we need to use the GLIM also to recognize and introduce skeletal muscle mass in clinical practice. Obesity is an important subset of the clinical population, which is more and more relevant. The GLIM is alive and kicking and going on with many, I think, exciting initiatives and perspectives. I just would like to mention that for the inflammation criterion, for instance, I'm coming with 2 or 3 minutes to conclude. Mr. Moderators, I hope that I have 2 or 3 more minutes. The algorithm contains other criteria, of course, that are relatively easy, but not that obvious to implement in clinical practice. So, for instance, for the inflammation and disease criterion, there is a GLIM inflammation working group that is being established in 2022 and is led by Tommy Siderom and Gordon Jensen. Again, there are many experts included in this group. I will not name all of them. I think that this group is advanced in the preparation of a manuscript which will try to clarify even better whether we can just use the diagnosis without measuring inflammation to implement the criterion. For instance, if we have a cancer patient may have, very different stages in the natural history, stages where there is an inflammatory complication, when inflammation is very high, but also stages where CRP and inflammation is not present. But are we allowed to exclude this criterion just because we are not finding inflammation at one specific moment? So this is going to be one of the questions to clarify. And also technically, what are the markers to be accepted? What are the thresholds? I think it's a very interesting and exciting story, and I hope that in a few months there will be a paper also to address this topic. Also, how to screen. It's an important concept. We know that screening is a world apart. It's sometimes screening is considered to be very extensive, and maybe too extensive. Screening should be simple. We need to maybe optimize screening tools for different clinical settings, different outpatients, inpatients, different specialties. So this initiative is also, I think, very important to clarify what is the optimal screening before the GLIM. And then we have a more political group which is working on how to overcome the barriers for implementation of the GLIM. We need to try to convince, we need to try to maybe change habits, which is not always easy. People are used to, let's say, implement other tools. We don't want to change this, but we want to have more and more malnutrition diagnosed. This is the most important goal. So in using the GLIM, I think is important to increase the recognition of malnutrition in our patients at any level. So my conclusions are the GLIM criteria may represent a historic, again, I may be biased, but I think it's a very important achievement in the field of clinical nutrition, since the GLIM allows for simple, accessible, potentially interdisciplinary identification of malnutrition at a global level with a common language and a big consensus in our community. Available data so far, they support the validity of the GLIM diagnosis, and they indicate an encouraging start with acceptance and implementation. Further clarification and guidance is available for criteria implementation of muscle mass, and it is planned for other criteria, now for screening as well. And the global consensus and I would say political strength from the global consensus should be used to advance clinical, scientific, and also, again, political recognition of malnutrition and clinical nutrition at large. So I really think that this is a global initiative, of course, and this was, I think, something that was from the start meant for global planning, but also at a country level, each country, each society. I'm sorry, this is I think a Portuguese slide that has slipped through the cracks. But in Spain, I'm sure in Italy, we should use the GLIM in our national context. We know that national healthcare systems are different everywhere. We need to use and optimize the implementation based on our regulation and our, let's say, limitations also sometimes that are very practical and very different in different places. And I would like also to send a final invitation to consider attendance. I know that SENPE is also very strongly participating in the ESPEN congresses. You have already, I think, SENPE is, Spain is one of the top 3 or 5 submitters of abstracts this year already for León, and I hope that there will be many of you attending the ESPEN Congress in León, France, from the 11th to the 14th of September. So please save the date and come to León to also continue to discuss about the GLIM, and thank you very much for the invitation and for your attention. Thank you.
No hay preguntas. Thank you very much, Dr. Barazzoni. It was a splendid lecture, and I think we have learned a lot of new things. Particularly, I was interested in sarcopenic obesity, and you covered the topic very well. Muchas gracias por su asistencia y se levanta la sesión.